Early raindrop outcomes and what to expect. Knowing what to expect in the first 3 months after implantation of the Raindrop Near Vision Inlay will give the new surgeon or staff member a level of knowledge and confidence in treating presbyopic patients who seek to improve their near vision. In this video, we will discuss what to expect immediately after surgery on day 1, week 1, month 1, and month 3. Specifically, visual acuities, topography, slit lamp findings, and ocular medications will be detailed. Keep in mind that not all patients heal at the same rate, so there may be some deviation from what will be outlined, but in general, this will serve as a guideline. Immediately after surgery on day 0, some results are similar to LASIK. The patient may have some mild discomfort and tearing. The vision, however, may be blurrier than immediately after LASIK. It's very important to check the centration of the inlay at the slit lamp and that the flap is properly repositioned. If the inlay is not well centered, return to the laser suite, lift the flap, and recenter the inlay. All post-op drops should be BAK-free to avoid the possible associated toxicity and subsequent inflammation. As with LASIK, an antibiotic should be used 4 times per day for 1 week. Patients are strongly encouraged to use preservative-free artificial tears at least 4 times a day. Please avoid the perioperative usage of brimonidine, as this may lead to flap dislocation and inlay decentration. Lastly, advise the patient to use an eye shield, especially at bedtime, to avoid eye rubbing, which could also lead to complications with the flap and inlay centration. On day 1 after surgery, expect the distance visual acuity to be blurry and the near vision to be focused at a very close distance. This is due to a large initial central corneal steepening and subsequent myopic shift immediately after surgery. When assessing the improved near vision with the patient, use a reading card and ask the patient to read the smallest line possible at their preferred reading distance. Then ask the patient to move the reading card closer to them to see if the near vision improves. Over the next week and month, the reading distance will move out to a more comfortable distance. During slit lamp evaluation, determine if the inlay is still centered. The most common path of inlay migration is in the downward, slightly nasal direction. If the inlay is decentered greater than 1 millimeter with accompanying reduction of near visual acuity, and the flap is clear, return to the laser suite, relift the flap, and recenter the inlay. If there is substantial flap edema and inlay centration is too difficult to determine, wait and reevaluate in 1 week. An edematous flap may also lead to an inlay migration, so it is crucial to reevaluate after the swelling reduces in the flap. Review the ocular medications with the patient. They will be using both antibiotic and steroid drops 4 times a day for the first week. Advise the patient to use preservative-free artificial tears at least 4 times a day, but not at the same time as the other drops, to avoid washing away or diluting the medication. At the 1-week visit, the distance visual acuity will be less blurry and the near visual acuity will be focused less close. The near focal point should be about 20 to 30 centimeters away. Most patients are adapting to their improved near vision but may still need glasses for extended reading periods. Again, the slit lamp exam should concentrate on inlay centration and flap issues, similar to post-LASIK. If the inlay is decentered, the patient has still no significant improvement in near vision, and the flap is clear, relift the flap and recenter the inlay. Because the cornea and vision are clearer now, patients with a decentered inlay may complain of poor near vision and/or monocular diplopia at near. The distance visual acuity will probably be clear if the inlay has migrated inferiorly. In reviewing the post-op drops, the patient should now be using the strong steroid drops 3 times a day for the week, tapering to twice a day next week and once a day the following week. Be sure the patient has the mild steroid drops ready to go immediately after the strong steroid drops taper, because it is important that there be no gap in the steroid drop usage. As always, continue with preservative-free artificial tears to prevent dry eyes. By the first month, the uncorrected distance visual acuity should continue to improve. The near visual acuity focal point will move to a more normal position around 30 to 40 centimeters away. Keep in mind that smooth surgeries with uneventful post-op conditions will result in better early outcomes. Be sure to take a topography at this point, as it will serve as a reference point for future ones. Slit lamp evaluation should be straightforward, as inlay positioning is now stable and the inlay and cornea should be clear. If not, the patient may not be compliant with the steroid drops. Treat the ocular surface and dry eyes aggressively. Cyclosporin ophthalmic emulsion every 12 hours, lid hygiene, and nightly gel or ointment should be considered, as well as punctal occlusion for non-MGD patients. The patient has now completed the strong steroid taper and the mild steroid drops or gel have started. Prescribe a BAK-free mild steroid twice a day for 1 month and then once a day for the next month. As always, encourage the patient to continue using preservative-free artificial tears. By the 3rd month, the Raindrop patient should be relatively stable. The distance and near visual acuity should be stable. The topography should be similar to the last visit. Slit lamp evaluation will reveal stability in inlay position and central clarity. There should not be any haze at 3 months, but if there is, the patient was probably not compliant with the steroid drops, so restarting may be necessary. There may be a faint white circle of deposits around the edge of the inlay. This is a normal finding and treatment is not needed. If haze is suspected, please refer to the Diagnosing Haze video. The 3-month post-op steroids are now completed. Continue using preservative-free tears and treating dry eyes. If all looks quiet and normal, have the patient return for the 6 and 12-month follow-up visits. At these and all future follow-up visits, look for stability in visual acuity, refraction, topography, and slit lamp appearance. It is recommended that patients be seen every 6 months after the first year.